Caroline Maurice Tillett, who is our care homes leader, effectively, and our QI lead within the AHSN. And Caroline's worked with lots and lots of care homes over the past few years on a program called SPICE, which has absolutely, benefited care homes and proven, significant reductions in falls and deterioration, etc., as a result of that program. We're equally joined by Steve Fawcett. So many of you will know Steve, Medical Director for North Staff's Clinical CCG. And Steve will set out that real context of the plan for Staffordshire Stoke moving forwards and how all of this will align into the deterioration networks, and then the expectations moving forward with that at the end with a bit of an ask. We're virtually joined by Dr. Alison Tavarai. So Alison is an RCGP lead for primary care and deterioration, and she's from west of England, but is a known lead in this area. So she's kindly recorded a video for us that we'll play during the session, and that will pick up some of the points of the evidence base behind some of this. And then we're joined equally by Leslie Roberts. So Leslie's the Senior Clinical Operations Manager as part of the CRIS team. So again, it's really important that we start to tie some of these alignments together and understand the whole pathway. So we'll be sharing with you a clinical escalation pathway, the first to see it really on the grander scale, that we're going to share with care homes moving forwards to understand how it all pieces together in terms of escalation. Next slide, please, Naz. So in terms of the agenda, we've obviously introductions and housekeeping. We hope that you're all at the right session, and we really want you to get the most out of this session. So like Sarah said, please do use the chat, and there'll be opportunities later on to ask questions verbally as well. Steve's going to run us through that local care home initiative within Staffordshire Stoke. I'll give a bit of an update of the national context of how this aligns. And then we're going to go really into the nitty-gritty of the session, if you like. So we're going to start looking at frailty, soft signs of deterioration management, use of SBARD, News 2, etc., and how it all sort of links in. We'll then hand over to Alison Tavarai's video, and that's quite a lengthy video, but really, really beneficial for us all to understand how this applies to us and the evidence base behind all of that. And then in between that, there'll be a little bit of a touch on quality improvement, the ask for care homes really, and what we're asking them to do in a session that we've already had with them, and we'll pick that up there. And then back to Steve for next steps and the vision, with a finish on question and answer sessions. I think on the updated agenda slide is that we'll have Leslie speaking to us as well about the CRIS and the clinical escalation pathways that's being developed. So at this point, I'm going to hand over to Steve and formally welcome you. So thank you very much, Steve.
Yeah, thanks very much, Dan. So just for colleagues, I'm by no means a subject expert. Like many people on the call, I'm a jobbing clinician in primary care. I've been a GP in Stoke-on-Trent for probably 25 plus years now. But I have got a substantial interest in care homes and how we can improve outcomes, particularly because I've been involved in some of the work around urgent and emergency care. But I'm also aware of the challenges that people have in looking after care homes, because let's face it, they are effectively mini hospitals now. For those of us old enough, we can remember geriatric hospitals, and some of the care homes I've visited over my time are by no means any different to the challenge they used to face there. So in terms of the context, can we go back there too? So in terms of context, I mean, there are a lot of care home beds in Staffordshire and Stoke-on-Trent, at nearly 9,300. And of course, particularly in the nursing home segments, those patients are often very frail, with multiple long-term conditions, and being very sort of frank, that they have often limited lifespan, so they often need quite a lot of support. The other challenge, of course, with care homes is that the residential and care homes to a certain extent is staff training and staff support and mechanisms to manage risk. What we have seen during COVID, which has been really helpful, is an increased use of remote consultation. In fact, remote consultation was a lifesaver for many of us, particularly around care homes, particularly when during the first wave, when the infections were raging through the homes. And people were actually encouraged and did take up lots of innovative ways of managing things. So certainly in the north, we had a substantial text program using remote monitoring equipment that allowed colleagues to do pretty thorough assessments, up to including electronic stethoscopes and so forth, which didn't require face-to-face consultations. What we found is that the problem with the care homes, though, is generally that the patients that you're asked to deal with are often have lots of different issues, and the symptoms tend to be not that clear. So people don't present with chest infections or urinary tract infections or pressure sores, whatever. They present with, they're not quite right, we're not quite sure, and it's this lack of a sort of standardized approach among care staff that drives most of us in primary care bonkers, because you're getting sort of vague concerns, but without any sort of hard, fast metrics or any sort of structured reporting, and that's a problem for the care staff, and it's also a problem for us. The end consequence of that is that they often escalate these patients inappropriately, so they'll either escalate them too early or to the wrong people, or they'll escalate them late when actually intervention becomes much more difficult. What we have also identified is that we need to have appropriate assessment so that we can get advanced care plans in place. So there's been a big drive over the last year to get respect documents, and there's and we need to give a shout out to all of us, because the work that's gone on and respect uptake has been really really impressive. But I think it's important that to support care homes, that those respect documents and the advanced care plans keep going on apace, because that actually is one of the most helpful bits in terms of defining what they do in particular circumstances. The other thing we've done recently, as a consequence really of the Academic Health Sciences Network, is that we've finally agreed on a number of standard approaches. So the first, and if you like, the foundations is using the Rockwood frailty scale. I'm sure colleagues are mostly are probably pretty familiar with this, but it's the one which has the helpful diagram and little descriptions of the degrees of frailty, and that helps underpin some of the other work. But the other bit that we've done is we've had some very big workshops with care homes and other members of the multidisciplinary team to agree a tool that care homes and residential homes can use to monitor their patients. So we've agreed, and we've sort of standardized on the stop and watch tool, and also on something called the SBARD approach, which will be covered later on. But these are the tools to allow both the care homes and the clinicians who are looking after them in general practice and people like the quiz, allows them to talk the same language, and they're structured in a way that allows both residential and nursing homes to respond in ways that they don't now. Obviously, the response for nursing homes will be different from the residential, but even so, the tools that I think you'll find will help them and help you, and will reduce your work, I suspect, or at least allow you to manage that work in a different way. Can I have the next slide? So in terms of the care homes and Staffordshire and Stoke-on-Trent, in terms of the services that wrap around them, I mean, clearly colleagues will be very familiar with the DES-LES arrangement that came into place last year. Clearly that focuses a lot on proactive care, on having regular MDTs. I know those have been patchy because of support and disruption related to COVID, but nevertheless they're a big step forward in terms of providing care when it's needed, and identifying things that we can get in place so that people can be managed in situ if appropriate. So that's things particularly around respect, but also making sure they've got their pharmacy sorted out, making sure that we've got their long-term conditions under appropriate management. There are some other services that you may be less familiar with, because they focus on supporting care homes, and particularly care homes that are operationally challenged. So there's something called the PERT team, which you probably aren't aware of, but is there to support care homes that have operational challenges. So it may be staffing, it may be infection control, it may be a number of different things, but the system it supports that team, and it's a sort of joint venture between health and local authority. And it's quite important because we're all aware that some care homes at times will struggle, and it's useful to know that team's on site. There's also the CRIS. Now, the CRIS team, the Community Rapid Intervention Service, Leslie's on the call, and she'll be giving you a rundown of what that service does. But I have to tell you, I'm not saying it just because Leslie's on the call, it has been transformational for us in the North. Its ability to respond to patients who are frail and unwell, both at home and in institutions, has been terrific. Clearly, the CRIS extends up to Stafford and surrounds as well as the North. But on the positive side, there'll be a CRIS offering both from the southeast and southwest in due course, and that's been implemented. We also did a set of QI webinars or sessions for care homes. We had a really big uptake, actually. We had a lot of them attend, which was great. And we went, and that's where we started to roll out the SBAR and the Stop and Watch tool, and we've got more sessions planned with them. And the feedback we had after those sessions was really good. But the key here about making this initiative work is about getting people like yourselves on the call involved, because ultimately you need to be cited on the tools and methods that the capabilities that we're giving the care homes, so that you can talk the same language back to them, and you can have confidence in what they're telling you and why they're telling you it. The other bit is that, particularly around the SBAR tool, it will help reduce unnecessary calls, which care homes don't want to bother people if they don't have to, but it would be helpful if they could be do it in a structured and an effective way, if you like. Can I have the next slide, please? So this approach that we've had, and I probably should give a shout out to not just the AHSN, but people like Lisa Duncan in the background at the CCG, because we've worked really hard to bring all the partners. So the AHSN, the Deteriorating Patient Network, which meets regularly, has got members from all the providers, MPFT, North Staffordshire Combined Healthcare, from both the local authorities, from all the acutes. And having that forum together means that we've been able to make sure that we're all, again, supporting the process. We've all agreed on the standardized approach, and that's key. Because if we make it universal and everyone understands it, then it will make it effective. But we recognise that within care homes, this isn't a one-off event. We will have to continuously do, do educational and supportive events to make sure, because staff change and staff move on, to make sure that the tools are maintained and people understand them. We need to look carefully at the pathways that come out of using these tools. So it's not just simply a matter of identifying the deteriorating patient. There's also a bit about agreeing with local clinicians, maybe at divisional or even ICS level, about how they want those deteriorating patients to be matched. So, for example, if you've got somebody with a chest infection or a subacute deterioration in the community, do we manage that through CRIS? Do we manage that through different methodologies? And I think it's important that all the clinicians are engaged in that conversation. I've mentioned about sustainable training. It will be like painting the fourth bridge. It has to be something that we actually embed probably in their induction, is my guess, and something that we will probably need to keep reminding colleagues of. I think the other bit is that whilst it's fantastic, we've got so many colleagues on the call. We need to recognise that there are a substantial number of colleagues who are not on the call, and so what I would implore colleagues to do is, after we've had the session, is to try and cascade this to colleagues. We'll record the webinars, and it will be made available in every place that we can put it. But it's important that colleagues are made more generally aware of it, because as the care homes start to feedback to people like yourselves or Grizz or other services, they'll be using these tools to describe the situation with their patient. And it's, if colleagues don't understand what these tools allow them to do, then they won't get the full benefit from it. And that's my last message, just to re-emphasize. There's benefits to both sides here, because what we want to do is to make sure that people have, your services are used when needed, but if they can be managed, if patients can be managed in a different way or more proactively, then that's also going to help everybody. So I shall stop there, and that's we'll have a chat at the end.
Thank you, Steve. That's awesome. If we could have the next slide, please, Naz. So Steve's given you that local context, and I want to back that up even further with the national context. So one of the national programs under the patient safety strategy that was released in 2019 is managing deterioration. And the primary aim of that program is about reducing the number of deterioration harms that we have across, acute, non-acute, care homes, etc. And by doing that, we'll use a framework called PIA. So PIA, for those of you that haven't heard this, is a national framework, and it looks at prevention, identification, escalation, and response. And they're the 4 areas now which NHSIE are really working towards with lots of programs, whether that be Aging Well, enhancing health in care homes, the DES, the urgent 2-hour crisis response, NHS at home, all of these sort of programs. This is very much about bringing those programs together into one place that supports whole pathway decision making, full involvement across an integrated system, and working together much more in primary and secondary care. With this in mind, one of the key drivers as part of the national programme that links into the Deterioration Advisory Board nationally is about managing deterioration in non-acute settings. So by that we mean GP practices and the PCNs, the care homes, domiciliary care providers, supported living accommodation with learning disability, offender health, so how we link into some of Her Majesty's prisons. But equally, it's about that alignment. Community teams, mental health teams, all working together to provide that wraparound support to some of those most vulnerable patients at risk of deterioration within our settings and place-based areas. So with that in mind, one of the key deliverables is that by March 2024, 80% of all non-acute settings will be expected to be using deterioration management tools like the ones we're going to show you today, and not exclusive to those tools. So different areas might use subtly different tools, but have the same approach and methodology as we're taking here. So there's an expectation that all of the 15 sub-regions across England will have a deterioration safety network regionally. And those have already started to commence. But in the West Midlands, our approach is very much that we'll have one of those deterioration networks within each ICS setting, because actually that's where the critical decision making needs to happen, not at a regional level, where we know that there are differences within place-based areas and within sort of sub-regions, etc., but making sure that we have that alignment across. And the models and the process that we're sharing with you today has been shared nationally, and it's been acknowledged that the West Midlands is already quite far ahead in terms of how we're progressing forward with the national agenda. It's really important to note that one of the other deliverables nationally is that there's an expectation that 60% of all care homes will be using deterioration management tools for frailty and to identify soft signs and news to where applicable, certainly for nursing homes, and linking that to end of life and personalised care support plans, etc., by March 2022 to have 60%. Now that's quite an ask. So in the West Midlands, there is about 1,677 care homes at the last count. So 60% of that is roughly 1,000 care homes to be using and fully adopted those tools by next year. Hence, one of the approaches is this webinar series of mass training, mass support, but really keying into that sustainability piece that Steve talked about. How do we make sure after the webinars that care homes are still using the tools, can still access them, can still ask questions, and have the support from local quality teams within their own areas from local authority or CCG. So we could have the next slide, please, Naz. To break that down further in terms of the peer framework, we see it as 4 areas nationally. At first is frailty recognition. You know, if we know which of our residents are the most frail, we can establish those plans in a much more timely manner. You know, so rather than waiting until somebody's severely frail, according to Rockwood, we move that back until they're moderately frail. And when they're moderately frail, start having some of those more in-depth conversations with that resident and their families about their wishes and wants moving forwards, because we know that there's an expected level of deterioration from somebody that's moderately frail within that sort of two to 3 year period. And that only exacerbates as we move forward in that frailty scale. It's then about that early recognition. And for that, we deploy a soft science tool. So identifying very quickly what are those subtle changes in a resident and how do we know when to escalate those. So like Steve said, it's lots of conversations about actually we've got a gut instinct that this resident's not their normal selves, or I'm not quite sure what's wrong with them, but I know something is. Well, these tools will help to look at what those subtle changes are. So rather than having conversations where we're not quite sure, we think they've changed, but we don't know how, we're not being able to specify some of that, we're enabling the care homes within the HSN and the CCG and all the partners in Staffordshire Stoke to be trying to use some of those soft science tools, in this case, stop and watch, so that they can escalate those and be really clear with yourselves about what they are. And to do that, they'll hand over using an SBAR, which we'll take you through. But many of you will be aware of SBAR, which has been used predominantly, you know, across the country in the NHS settings now for some time, but actually just an element added to that, which we'll take you through. And then it's really moving through to that acute phase. And what we're not asking care homes to do is make clinical decisions. That's for you guys. What we want them to do is understand when to escalate, to have already had internal conversations about, actually, we know that this resident has been subtly deteriorating, but nothing serious. So actually, how do we escalate this? Is it to CRIS? Is it to GPs? You know, rather than going straight for that 111 or 999. And sometimes that will be the solution. So as part of that, Staffordshire Stoke have developed a clinical escalation pathway, which we'll share with you later. And for nursing homes, that's very much about news too. You know, we expect that a nursing home should be quite adequately capable of undertaking a baseline set of observations for a new resident that comes into their care home, and that we monitor that over time. So then we're able to see the change in baseline to their current news and map and track that deterioration over time. And then linking all of that to end of life planning or personalised care support planning, as we now hear. And so many terms that we hear now: advanced care planning, personalised care support planning, treatment escalation planning. And I think there's lots of language issues there that we're sorting out nationally, but all meaning the same thing. You know, we all absolutely need to proactively plan for our patients, because we know some of them will go on to deteriorate and go into A&E, you know, and being turned around straight back to the care home is not appropriate. We equally know within the region as a whole, West Midlands have some real hotspot areas that demonstrate lower levels of residents staying in their preferred place of care for treatment and subsequently dying in their preferred place of care. And I'm sure that you're all with me that dying in an ED or on an acute ward when you've just moved is absolutely not the right thing that most patients want, or their families, and causes lots of stress. So this is about actually defining who needs escalating and when. You know, we absolutely know this is not about saying not don't send your patient to ED, because we know that some of them will need to go. But it's about making it more appropriate and making those pathways more stringent. If we could have the next slide, please, Naz. So at that point, I'm going to hand over to Caroline, who's going to take us through some of those tools.
Thanks, Dan. So just to reiterate what Dan said, so the first sort of area of focus is about increasing the understanding of frailty. And traditionally, I don't think frailty has been taught traditionally in care homes. And we believe that having a good understanding of where residents are on a frailty spectrum really will help to empower the staff within the care homes to maybe prompt some of those conversations about end-of-life care that may need to happen. Can I have the next slide, please, Naz? So as Dan and Steve have said, across the Staffordshire Stoke region, the Rockwood Clinical Frailty Scale is the scale that we're going to be promoting across the care homes. It's a very visual scale, and as you can see, it has got a very brief description. So care staff in the homes across the Staffordshire Stoke region are being encouraged to review their residents and sort of make an assessment of their level of frailty. And we're encouraging them to do that on admission, for a resident on admission. And every 6 months, really, we feel is frequently enough, unless a resident has had a lengthy, a couple of weeks stay in hospital, because sadly we know that when residents do go into hospital, they come out a lot more frail, than they went in, and that's sort of widely acknowledged and recognised. So I think having the care staff involved in undertaking 6 monthly frailty assessments gives them a sort of an objective way of assessing how residents are doing, because they see them every day. They may not notice those subtle changes, but when they come to do that frailty assessment and they recognise that actually when Betty came into the care home, she could potter around and get herself dressed, but now she's not doing that, she needs help with assistance with feeding, and that will help them to see that that resident has gone maybe from moderately frail to severely frail, and that might make it easier to have a conversation with the resident or the family members about what that resident might want should they, deteriorate at a certain point in time. So frailty scoring is a really good way of just raising awareness of the fact that frail residents, the very severely frail residents, are probably likely to die within 1 year of that diagnosis. Next slide, please, Naz. And I'm sorry if I'm teaching my grandmother how to suck eggs, but why is frailty important? Well, it is a long-term condition, and we know that for people that are fit and well, if they have a minor illness such as a UTI, they have a very small, drop the green line on the chart, and where they're a bit unwell, and then they get back to their level of independence that they were at before. But with frail patients, that minor illness has a much more severe impact on their dependence, and they are much slower to gain that dependence back, and they very often don't reach that level of independence that they had before, so they're worse after each of these sort of minor illnesses. So that's why it's really important for the care staff to understand that actually, yes, it's only chest infection or a UTI, but it does have a long-term impact. Thank you. Next slide, please. And we know, as I said, that people with severe frailty will die within 1 year of identification, and so that having those stark realities, care staff are more aware of that does really help them to think about what's best for the residents and think about the end of life planning that they may be able to have some conversations about. Nobody wants to die in hospital, and we want to promote residents to die in their preferred place of care, or if appropriate, be admitted and have active treatments. Thank you. Next slide, please, Naz. And you will be very familiar with this. There's lots of classic presentations in frailty. I'm not going to read the whole list, but things like constipation, breathlessness, increased falls, all those signs are probably ones that you're presented with on a daily basis. So just increasing awareness with the care staff really does help them to have an understanding of the residents that they're caring for. Next slide, please. Okay, so the second sort of driver that we talked about was about the early recognition of soft signs of deterioration, and there are a number of tools out across the country, including things like Restore 2 Mini, Stop and Watch, Is My Resident Unwell? And this one, Stop and Watch, is the one that's been advocated for the Staffordshire Stoke region. Essentially, Stop and Watch is a sort of a useful mnemonic, and so S stands for seems different to usual, T stands for talks or communicates less, etc. So each acronym gets the care staff to think about what is it that is different about this resident, and they can escalate that internally. And then make a decision about whether they need to escalate that further. They may well then go on to do a set of observations, particularly in nursing homes where they already use observations and News 2. They will then do a set of observations and may be able to calculate a News 2 score, which they can compare with their baseline News 2 for that resident. And that will, obviously, the more information that the carers can gather and hand over to you will hopefully make your life easier about making a decision. The care staff find this tool a very, very helpful tool. We know that we have a really high turnover of care staff. So, you know, we might have somebody in a care home that one day was working in a supermarket and now they're working in a care home. And it's probably that those new staff, the less experienced staff, that may find it difficult to articulate these soft signs of concern. And so this tool helps to shape and focus their attention to the areas of concern and to empower them to escalate concerns to a more senior carer or a nurse within the home. And then, as I said, go on to do some observations. It also acts as a record, because when staff may have actually gone on off duty when the GP or the ANP calls back, and so there's a sort of a record of what the concerns were and the observations at the time. So again, it's a really useful tool, and lots of care homes in other regions have been using this tool very, very successfully in their care homes, and they're finding it really advantageous for escalating residents of concern. So that's the Stop and Watch tool, the first side of the tool. And the next slide, I think, we have the next slide, please. On the back of that tool, there is an SBAR format, so that the staff can collect the right information, so they can hand over the situation that they're concerned about, the background of the resident, because again, you need to know, what their age, their diagnosis, their medicines, any relevant information. They provide the assessment, what's different, and any observations that are relevant. And a lot of residential homes are actually doing some observations now, and their recommendation, what is it they want from the call, and it helps them to gather that information and make the call, so that they get across what they want to get across, and that you have the right information with which to make a clinical decision. As we said, many homes, nursing homes in particular, are now using News 2, which is a standardised observation chart, which actually provides a score for each clinical observation, and you get a total score, which gives an indication of the severity of illness with a particular resident. And so where appropriate, we're encouraging and promoting the use of that. and the care homes that we've done the webinars with already have had training on the soft signs tool, frailty scoring, and the News 2 tool as appropriate. Thank you. Next slide, please. So we're just going to show a short video now, which we also showed to the care homes, and this actually is a very useful health education video, which just explains a little bit about News 2 for those that are less familiar with it, but this is something that all GPs should be using in their practice now. So we'll just show this short video now. Thank you.
Hello. NEWS stands for National Early Warning Score. The system is widely used across healthcare settings in the United Kingdom. It uses a set of observations or vital signs to quickly recognise if someone is becoming unwell. This is because a change in vital signs suggests worsening health. For example, a rise in heart rate or temperature may suggest an infection. The 6 vital signs used in NEWS are breathing rate, also known as respiratory rate, the level of oxygen in their blood, also known as oxygen saturation, heart rate, also known as pulse rate, blood pressure, level of alertness, and temperature. All of these vital signs can be easily measured in care homes. Each vital sign scores between 0 and 3. 2 further points are given if someone is on oxygen therapy. Once you add these scores together, you get a NEWS of between 0 and 20. The higher the score, the more unwell the person is likely to be. A score of 5 could mean the person is very ill. The person needs regular monitoring of vital signs whilst an urgent review by a doctor or nurse is arranged. If the score is above 7, the review needs to be very urgent. Many care homes will take a set of vital signs when a resident first arrives to help them understand what is normal for that individual. The new system helps care homes and carers to interpret the vital signs through a scoring system. Your organisation will advise how often you need to check an individual's vital signs. NEWS has been shown to help staff to recognise sick people more quickly and get help earlier. If someone becomes unwell, a carer can give the GP, 999 or the ambulance crew the news. This helps healthcare professionals to quickly understand how unwell someone is and how soon they need to be seen. NEWS has been shown to decrease the number of 999 calls and hospital admissions from care homes. Care home staff also report that they feel more confident and supported to raise concerns when using NEWS. This means that the safety of residents is improved and they have a greater chance of staying in their own home for treatment. It is important that you have been trained to use the equipment for taking vital signs. You will need to use a thermometer, blood pressure cuffs, finger or ear probes known as pulse oximeters for measuring oxygen levels, colour-printed news charts or electronic devices with news software, and a timer or device that can time 1 minute. All equipment must be regularly calibrated and checked. If you find any problems with any of the equipment, you must report this immediately. If you have any questions about NEWS, please speak to your manager or senior colleague.
Thank you. I did just ask a question in the chat box about how many of you are currently using NEWS, and we did have a couple of responses to that. I think I've already covered this slide. So SBAR, this is on the back of the stop and watch form, and that's the form that the staff complete prior to giving you a call. So it really helps them to gather the right information together and to escalate that to you so that you've got the right information to make a clinical decision. And obviously in the background, things like respect or DNA or CPRs or personalised support plans are also a really important part of that, as is the frailty score, which is also prompted on the back of this form. Thank you. Next slide, please. So I know there has been some concern that News 2 is has limited evidence in terms of community settings, and the evidence is increasingly coming forward. And at the end of this slide set, which you will receive as part of the follow-up from this training, there is a list of evidence bases for the use of News 2 in community. But I'd like to introduce Alison Tavares now, who, as Dan said, is a GP herself, and she's a sort of a national lead for deterioration, and she has done a webinar with us, which we
to speak today about managing deterioration in care homes. So thanks for asking me to speak today about managing deterioration in care homes.
Apologies, just a minute, we'll sort that out.
The work. So for those of you who don't know, the west of England, we're based in Bristol, but we also stretch.
Thank you. We'll just start that video again so it's syncing correctly. Thanks, Naz.
So thanks for asking me to speak today about managing deterioration in care homes. And I'm just going to share the work we've done in the west of England. Next slide, please. So for those of you who don't know, the west of England, we're based in Bristol, but we also stretch up towards Gloucester and out towards Bath, Swindon and Wiltshire. So quite a big area. And all the work I'm going to be sharing with you is being produced in collaboration across the area. Next slide, please. So what I thought I'd do was actually start with a bit of background. So I'm part of the patient safety team with a special interest in identifying the deteriorating patient and improving the management of the patient, particularly using News National Early Warning Score. And although there is some controversy with the college about whether the News should be used, and I'll refer to that later, and I thought I'd also share some evidence relating to the use of News in the community. So that's the work we've done over the last 4 or 5 years, but we're now moving on to working with care homes and collaborating quite widely across the area. So I'm going to share some of the training that we're doing, case studies. And then obviously, because it's very relevant, is briefly touch on COVID-19, because that's the deterioration we're all going to be worrying about over the next few months. Next slide, please. So I apologise if you know about News, the National Early Warning Score, and normally I can kind of look around a room and ask you to put your hands up if you know all about it. But I'm going to have to assume that for some people, structured sets of observations are new. So I'll just give a very quick overview. And if you do want to know more later, I'll put a link to the Royal College of Physicians website. So basically, objective sets of observations have just got 6 simple things. It's here, respiratory rate, i.e. how fast you breathe, oxygen saturations, pretty well all of us are on scale 1 unless we're retaining carbon dioxide, whether we're breathing air or oxygen, blood pressure, pulse, consciousness, whether you're alert or CVPU, so confused or responding only to voice, pain or unresponsive, and your temperature. Something that's always interested me is, in fact, when somebody's very unwell and with sepsis, they'll often have a low temperature. So do look at those scores. And the idea is that each observation will have its individual measurement, and most of us will be a 0, so will be a normal range. But then as you become slightly more unwell, you get a slightly increased value, and then they're aggregated up to give the total News National Early Warning Score. And version 2, News 2 is the one that's been adapted recently to include scale 1, scale 2. So its function is as a track and trigger score. And the idea is, or was in hospital, was that you measure patients' observations over time, and if the score goes up, then that could trigger an intervention such as a review. And that can be very relevant to me as a GP. So If it happened fairly recently, one of my colleagues saw somebody with a sore throat with a news of 3, but by the time she came to see me later that day feeling much worse with the news of 8, I had objective measure of change. And it's also a common language, so if you've got a higher news, then it's likely that you're more unwell if you've got a lower news score. Next slide, please. So I thought I'd share this slide, this case with you. I kind of got it out of the BMJ. And necrotizing fasciitis, I mean, I don't think I've ever seen it. But the patient presented with a lump in the groin. And imagine that you're in the surgery and one of the colleagues says somebody's got a lump in the groin and they come and give you this set of observations. You're looking at the respiratory rate, 28, and that's pretty high. Blood pressure, 85. Well, in an 80-year-old, that's really low. In an 18-year-old, that's about normal. So the patient's probably a bit unwell. Next slide, please. Now I've got the QSOFA, which is the Sequential Organ Failure Assessment. It was a hospital tool which they thought we could use in the community. And that's it. I've mentioned it here because it's referenced in the article, but personally, I don't find the two that helpful, but perhaps you feel differently. Next slide, please. And if you look at the news 2, using those same observations, that patient has a score of 9, but instantly you know that they're unwell. Now, what you're going to do with them is another issue, although the college do recommend, well, College of physicians recommend use of 5 or more think sepsis. But at least you've got an objective measurement of that patient, even if you haven't made a diagnosis of necrotizing fasciitis. Next slide, please. So that's kind of a bit of an introduction to news. And when we started, there was absolutely no evidence for the use of news in the community. And so we were very clear that GPs should make it a decision to admit a patient and then calculate the news. And by doing that, what we were doing was using a common language, but also starting the track and trigger element one step earlier. So by sharing the news from the GP into the ambulance service, into the ED and into the acute sector, we could share what the patient's observations were and their general physiology in a much more structured way. Thank you. Next slide, please. So it's very difficult when you're introducing something new, and this slide took a lot of discussion because we felt we needed to give people some idea of the numbers. We linked it to the Royal College of Physicians guidance and said 3 was threat, 5 refer, and 7 was severe. But we were absolutely clear that you couldn't ascribe actions to scores, because if my patient's got crushing central chest pain, it doesn't matter what their news is, they need to be admitted. If they've got a stroke, it doesn't matter what their news is, they need admission. So very much this was a this is a tool, a clinical tool to be used alongside clinical judgment. And again, just for reference, it's not used for children, not used for pregnant women, and you should be aware of other underlying conditions, which I'll come to later. Thank you. Next slide, please. So that was how we started, was introducing news as a common language. It was fairly easy to adopt in the hospitals. The nurses took it up fairly easily in the community. GPs were a bit more of a challenge. But what really started to change was that our GP colleagues who triage the admissions for the acute sector started asking us for a full set of observations, because they've always had to decide where our patients are seen, by whom, and with what degree of urgency. And so these are very broad brush strokes, but the idea was that if a patient had a news of 3, normally seen on the acute medical unit, but we discussed alternatives to discuss it might be a hot clinic, same-day clinic, surgical hot clinic. It really helped to having those discussions. News of 5, they were normally seen in the emergency department, and a news of 7, again, the emergency department was a blue light admission. And that, for me, the GP was really helpful. So the case I mentioned earlier was a woman with tonsillitis. In fact, who had a tonsillar abscess. As I say, her news had been 3 in the morning. By the time I saw her, it was 8. It's really helpful for me to be able to communicate that rapid deterioration to my secondary care colleagues. But it also helped when I requested an ambulance, because they started to ask for news, and I was able to give her news of 8, and they were there within 10 minutes. I don't know about you, but I'm sure most of us sat there thinking, so how am I going to transfer this patient and what level of urgency do I request for an ambulance? And that's really helped me with my decision making. Next slide, please. So that was our vision, was to use it as communication, but this is the first time we could see our vision actually coming into reality and working properly. And John Rees is a GP in Bristol who'd come to one of my talks, so heard about you. And he was asked by one of the nurses to see a man who'd just come for a dressing change. So we're going to talk later about soft signs. And the nurse just felt there was something wrong, you know, nothing specific. And the gentleman hadn't presented as an emergency. So John saw this patient, Paul is called, took a full set of observations, news of 7, and decided he had sepsis secondary to cellulitis. Called an ambulance. By the time paramedics arrived, news was 8. By the time he arrived in the ED, his news was 9. So you can see that actually the high news helped to identify this gentleman was ill. But by tracking it over handovers of care, we also were able to have objective evidence that this gentleman was getting more unwell and quite rapidly. And in fact, if you look at the news we've added at the bottom of the slide, it actually went up to 11 before he was given fluids and antibiotics. But he was treated within the hour because the ambulance were able to pre-alert our ED consultant, and the gentleman was home within the week. And that's in a man who hadn't actually presented as unwell. So you can see that communication. If you have a look again, I put a link there, a slide. If you look at weahsn.net, there is a video there. I've had over 30,000 views just showing you this actually in action. Feel free to share it with your colleagues. Next slide, please. So obviously that was the clinical idea. We could see it working, but we wanted to collect the evidence, and we've worked with our local CLARC or ARC now, academic research collaboration. And one of the bits of work was on was qualitative. Nurses particularly found it helpful, our acute, our advanced nurse practitioners, because a lot of them had previously found it a challenge to get patients admitted, and being able to share news made it much easier. It also made admitting a patient much easier for GPs. But the bit that really surprised people, and actually surprised me, was actually taking news and a full set of observations was evidence of a full examination and actually supported the decision not to admit somebody. And I think that's really important because there's been a lot of controversy when people say using news will admit more patients. But personally, I've admitted fewer. And I think it's because I have evidence that I've examined a patient properly at that time. But also, if they then represent and they've had a full set of observations, there's objective measure of change. And bear that in mind when I come on to a slide later with evidence of changes in admission rates. Thank you. Next slide. And as part of the work, this is actually in the emergency department, but it was just to kind of give you a flavour of what the news actually meant, because people said, oh, well, we know what the news is of patients in hospital, but they're a very different population to the patients who are being seen either in the community or being admitted. And that we haven't found that to be the case. And as you can see, the higher the news, the more likely you are to be admitted, the longer you stay, and the more likely you are to die. But look at the news of 9 or more. And this, I gave a talk in Cork about this work, perhaps the Royal College of GPs in Cork. And one of the patients with a score of 9, greater than 9, wasn't actually admitted. And that really reinforces what I was saying earlier, that you can't ascribe actions to specific scores, because it has to be, you have to look at the patient in the whole context. And we've not been able to link outcomes, specific patient outcomes, to the news. So I can't tell you for certain, but I presume that that person with a score of 9 or more probably was end of life, and therefore admission was inappropriate. That has been published, so you feel free to look at that in more detail if you want to. Next slide, please. And then this we've just had published in the BJGP. So this is, as I said, we had to actually give news on admission. In one of our trusts, we looked at all the news scores. There were over 13,000. And a lot had scores of 0 to 2. Interestingly, 22% didn't have a full set of news that's not recorded. But actually, I think a lot of them were incomplete news, because I know the GP, if someone's got false mail, I work with students who a lot do have shellac nails. You can't get a full set of observations because you can't do pulse oximetry. But again, a similar finding is the higher the news, the more likely the patient was to be admitted, more likely the patient was to die, the more likely they were to have sepsis. Next slide, please. There's been concern that we should, that using news increased admissions. I'm sorry, it's not a brilliantly dark, easy slide, but we're at the bottom in pink. And actually, although the increased rate of admissions is no greater than anywhere else. And I think that's because I've been more confident to not admit patients. Next slide, please. But the Patient Safety Measurement Unit looked at our work, and I realise this is an older version of the slides. SOS is suspicion of sepsis. It has been published in the BJGP, but this is an SPC. It's a bit like a run chart, and we've got a special course variation, which they've attributed with the Patient Safety Measurement Unit, part of NHSX, have attributed to the use of news across the system. Have a look at the paper in the BJGP in June if you want to know more. Thank you. Next slide, please. So that's the work we did on deterioration, but now we're very much moving into care homes. We started doing this about 18 months ago, and it was only just over a year ago we decided to look at resources, and we were awarded a grant by Health Education England to produce 14 videos, looking at simple things like communicating using SBAR tool, how to measure blood pressure, how to measure pulse oximetry, and these resources are freely available. You can all use them. I put the links there. They're on Health Education England YouTube, and they're really popular with care home staff. And this was a case that shared by our hospital at home team, because again, slightly different to the care homes, but if you're taking observations, then you can have objective measure of change, because it's that common language that it's not just saying, I feel somebody's deteriorating, but you can objectively measure their change in their physiology. And in this case, this gentleman's deterioration was picked up early and treatment initiated. Thank you. Next slide, please. And you may be sitting there thinking, oh, well, actually, the news are going to be high for lots of our patients, residents in care homes, but in fact, that's not the case. And I point you to the work done by Rob Barker and colleagues in the North East. They've done some great work in care homes. And actually, the median news was 2, and 66% of this 19,000 residents had news of 2 or less. So our patients often are have much better, that their physiology is likely to be in a normal range, more cases than not. So it's worth knowing what's normal for your patient. Next slide, please. And that's why I thought I'd share this patient. Again, duty doctor, it's a recurrent theme. They're the patients I don't know, which is why it's so helpful. And this woman came to see me, known COPD, and we started, or we have started taking baseline observations when we see patients for their annual checks. And she came to see me, she had sudden onset shortness of breath and pleuritic chest comfort in the night. She was adamant it wasn't a usual exacerbation. And if you look, her respiratory rate was 24, whereas it had been 18 a few weeks previously. Stats were about the same, but she was really quite tachycardic. Afebrile, as I said earlier, that doesn't go against infection. Some people who are significantly unwell are unable to mount a febrile response. So I admitted her, in fact, query PE, because she's got a need for. I was wrong. In fact, she had got an exacerbation of her chest infection. But for me, it was just helpful that I was able to say there was objective change, because I knew what her normal baseline was. So if you know what's normal for your residents in your homes, that can help you with your decision-making and communication. And this is my nephew, Toby, who's actually got Worcester Drought syndrome, so named after your area. It's a very rare autosomal recessive disorder called profound and multiple learning disability. So he gets recurrent aspiration pneumonia, and I'm sure has had sepsis on occasion. But it's very difficult for my brother and his wife to communicate to other people that he's unwell, because he just becomes very, very quiet. And as you can see, although he can't speak, he's very lively. So I taught my brother how to measure news, and when Toby became unwell a few years ago, my sister-in-law measured his news, took him into the ED, and just said, I think Toby's got sepsis. The ED consultant said, I don't believe in news, but the thing was he got treated promptly. It was sepsis, and he was home within a few days. And that's some work that I'm working with NHS England. The Acute Deterioration Board is actually whether we can use news to support families and carers and identifying somebody who's unwell. So what's happening with COVID, and this is the British Geriatric Society, and their recommendations for COVID are that staff should be trained to take temperature of residents, and if possible should be trained to measure other vital signs. And we know that not everybody's able to do that, but that's kind of something that's being encouraged, particularly with COVID. So again, have a look at the guidance if you want to know more. It's updated regularly. And the reason physiology is important is this came from Martin Kim, who's one of the national leads for NHS at Home. And you can see that the lower somebody's oxygen saturations, the greater the mortality. So the idea is soft signs of deterioration, and then patients will be assessed with the knowledge if they've got a treatment escalation plan or a tool such as respect, with giving a guidance for their wishes, whether they're severe and need to be admitted, whether they're moderate and may be kept at home with monitoring, so with oxygen saturation, as I suggested earlier. And so actually, how does this work in practice? So I've just mentioned the SBAR tool, so situation, background, assessment, recommendation, and decision. And part of the background is awareness of whether people have made advanced care planning. Next slide, please. And it becomes very relevant here, which was shared by one of my colleagues. A gentleman in his 70s had a stroke, needing full supportive care, but fully able to participate in decision making. And he'd completed a respect form, and it was absolutely clear that if he were unwell, he wanted to be admitted. He was unwell, he had possible COVID, this was back in April, reviewed by the GP and everything normal range. Next day, seen by a colleague of mine, again duty doctor, and he deteriorated, oxygen status of 89 and respiratory rate of 28. Bearing in mind, he was absolutely adamant, had been absolutely adamant that he wanted to be admitted. But interestingly, when he became very unwell, and because in the time of COVID, he didn't want to be admitted. So there was objective evidence of physiological deterioration. The care home knew his wishes, but the care home staff also knew that he changed his mind. They had these discussions and decided that, yes, he was unwell, but he had changed his mind and he didn't want to be admitted. And I think that just shows that collaboration which we all want, because we identify that somebody's unwell and we can manage deterioration by admitting, but we can also manage deterioration by keeping gentlemen at home, which is what happened here, and he fortunately recovered.
Thanks, Naz. We'll just go back to the slides now, but I think that short presentation by Dr. Tavares is really helpful, and hopefully some of those clinical examples will have been very familiar to you. And I think particularly her focus on the soft signs, having a baseline News 2 score, and those discussions around end-of-life care will have drawn out some thoughts from yourselves. So Dan's going to pick up from now, because we're going to talk to you about where we're going, what we've sort of outlined with the care homes, about what we want to achieve, because this is a big piece of work and it needs sort of chunking down into manageable chunks. So thanks, Dan.
Thanks, Caroline. So in the first webinar for care homes, and there was about 80 care homes on that webinar, as Steve said earlier, with another IT that had requested recording because they couldn't attend the session live. So about 160 care homes within Staffordshire Stoke already starting to understand some of this piece of work. But that first session focused in on sort of chunking it up, like we said earlier: frailty, soft signs, acute deterioration, and end-of-life planning, or personalised care support planning. And it asked those care homes some really pertinent questions around how they were going to move this forward, what this means to them. So do they know how many residents within their care homes have a frailty score? If they don't do frailty, then clearly there's a need there to implement the Rockwood tool. But where they had got it, was it consistently implemented? So had all residents got a frailty score? Were they regularly updated in line with those parameters that Caroline set out earlier in the call? So sort of 6 monthly after being taken baseline on admission, or sort of nominal deterioration within the home or within a recent admission from the acute setting. Did they know the process? So did all staff know that process? And if we were to ask 10 staff in the care home, would they all tell us the same thing? If not, then actually there's some learning there human factor wise about it's probably not implemented as strongly as we would like. And then to ask a series of questions then depending where they were at with this process. So soft signs, do they use the soft signs tool and the stop and watch already? Are staff trained in that? And do they understand how to escalate concerns using SBARD? You know, simple questions, but actually it's a sort of ask for the care homes to go back with their staff and start planning around how they're going to implement this. So what we did for the care homes was look very much about quality improvement methodology to support and underpin their approach to implementation. So if we can have the next slide, please, now. And we use the model for improvement, which links to the IHI. And that sort of draws down 3 very pertinent questions. 1, the aim, what are we trying to accomplish? 2, the measures, how will we know that that change has resulted in an improvement? And then thirdly, the changes. What changes can we make that we know will result in an improvement? Well, the changes are a given. So the changes are the tools that we're supplying them. The aim is that we're trying to increase the number of residents staying and dying within their preferred place of care, but ultimately in decreasing the number of residents going to ED as an avoidable presentation or admission. You know, so avoidable meaning that they've been either turned straight back from ED or admitted for less than 24 hours to the secondary care trust. We want to track that number because actually, could that patient have been managed in a different way? And that's really key that we start to learn some of that moving forward. So care homes were given that sort of chance to really think about, let's not go and try and implement every single one of these tools in one go, because that would be too difficult. But actually, where do we need to start and focus our attention? Is it, I mean, if we've not got frailty at all, then that's an obvious start, that we implement the Rockwood tool as a starting point. Now, those free webinars that we have with care homes are on a monthly basis, so that each month we can see the progress of each of the homes in terms of implementation. And by that 3rd webinar, the hope is that they've implemented and they can share some of that learning and best practice with their peers and with the staff and colleagues from other agencies. Next slide, please, Naz. And we taught them through, you know, the need for a really smart and specific aim, you know, and framing that in the context of positivity. So increasing the number of people that stay within their preferred place of care, you know, increasing the number of residents that have had a frailty score in place or a baseline score in place, and then increasing the number of stop and watch tools or staff trained around that tool. So that QI methodology underpins the care homes then being able to go back and deliver this, because what we know from previous works where we've done this approach is that care homes tend not to be able to go back and implement unless they're given that specific time to do this and supported by the methodology. So they really start to understand quality improvement, and that's what started to come out in the first session. Next slide, please, Naz. And there's just a series of aims there that are shared with the care homes in order to give them a bit of focus about what they're trying to achieve. What they're told very quickly in that is that they need to go back and stakeholder map with their teams. You know, this is not seen as just for senior carers or nurses. This is for everybody within that staffing structure. So actually skilling up a domestic member of staff to recognise that actually a resident's nutrition might be starting to decline or deteriorate. And then what does that domestic do to it? So that with that information, who does she escalate to? You know, is it that we complete the stop and watch tool at that point and have a discussion with the more senior carers? So this is everybody's business within the care home, not just one or two members of staff. Next slide, please, Naz. And a key part of this is the understanding measurement. So what we really want to demonstrate at the end of this is a series of increases in process measure, like the number of residents with a frailty score or the number of staff trying in the use of stop and watch, that ultimately leads to outcome measures. And those typical outcome measures, reductions in avoidable ED admissions, a reduction in ambulance call-outs. We probably expect in the interim that there'd be an increase in rapid response referral, which I'm sure Leslie will pick up when I hand over shortly. But actually that we have really structured pathways in place to recognise measurement. Now, part of the work that the Deterioration Safety Network are going to do moving forwards is look at how we track that for each care home. So one of the ways that some of the other ICSs have been doing that is exploring the HES data and the WOMAS data, so the top fallout homes, and then tracking them over time. So mini run charts within each individual care home. So hence we teach the care homes how to monitor some of their data, and we use a tool there called the Safety Cross. A very, very easy way and a visual way of care homes being able to track their data on a daily basis in terms of deterioration. And that's really pertinent because then if staff start to see improvement, you know, much like that QI, any laggards to that will get onboarded quite quickly. And there's an expectation then the care homes start to see the improvement themselves. And then that tracks into deliverables that you're all hoping to see. Next slide, please, Naz. So it's equally important that those care homes recognise success. So one of the key features of the webinar series is that by the third webinar, we start to celebrate where they've come from and to. And that includes yourselves in that as well, because we know that you're providing those wraparound services of support that are really pertinent to the care homes delivering this piece of work and ask from us and from the Deterioration Network within Staffordshire Stoke. And of course, it's really important to note that this is the first step. So this is a 3-year piece of work, and it starts with care homes, but then it moves into domiciliary care and family carers, you know, because actually they're the areas that equally, with use of the tools, we could really move forwards. And for example, so my mum is a carer for my nan, and I've taught her the use of these tools, and now she feels far more confident when to escalate and when to identify those subtle changes in nan's moods or behaviours or physical condition. So there's a real opportunity to move forwards across the next 3 years with this and have a common language across the whole pathway. Next slide, please, Naz. And here you can see, this is what we'd start to expect to see moving forward, probably not within the 3 months because it would be too premature, but certainly within a year, we would expect to see a number of shifts and trends within the data that move towards improved outcomes for patients, and ultimately a reduction in deterioration associated harm. And that's the key that we're trying to achieve here. You know, that actually we pre-plan with our patients who most need that planning support of personalised care support plans. You know, we know those residents most at risk of deterioration, and we know which ones need escalating and when, and how to identify them. So that's part of the sort of approach that we've shared with the care homes in order for them to understand how to implement. And we'll revisit that within the second webinar. And care homes find that really valuable to understand the methodologies and go back with something to support them. Next slide, please, Naz. So I'm going to hand over at this point to back to Steve, who's going to set out some of that vision and next steps for us. So I can hopefully, yeah. Thank you, Steve.
I wasn't sure if it was going to work there for a second. And again, thanks for the HSN team for giving a really informative presentation. I think in terms of the next steps, as I said during my sort of early preamble, was that this will be an ongoing process, and we will have to keep revisiting parts of this as we go along. In terms of trying to make it all work, I think it's important to recognise that it's not just primary care that are in this. It's about how we work together with the community teams, how we work with the ambulance services, how we work with local authorities for that matter, because they've got a big role to play in this, because ultimately they commission care homes and nursing homes, and we, the health services, don't. Again, some of you will be from parts of the county where the CRIS is not fully enabled or rolled out yet, but as I said again at the beginning, they are a huge enabler. Leslie will give you in a minute a view from the CRIS team in the north, but they are a game changer in terms of supporting these frail patients. Using the stop and watch, I mean, the first most critical step was for us to agree on a tool that we could all sign up to in terms of local authorities, care homes and so forth. But the key bit is for us to make it common currency so that everyone is understand in the same way that we now have a common currency with the respect form, we have a common currency with stop and watch, so that everyone knows when they're talking about a patient what they're meaning, and there's the ability to manage them better. There's the ability to refer to enhanced support, and that will be for MDTs and community teams. I think I said at the beginning that some of the other care home support teams will be invisible to you because they're not really relevant for your day-to-day work. But of course, you've got the ARRS roles coming on in terms of the PCNs, and I'm sure that will facilitate. The weekly MDTs, which again have been during the COVID pandemic, particularly as community teams have become have been pulled into other activities, they're now fully going back to business as usual, and those MDTs will be important. One, because you can try and proactively manage those patients so that colleagues know what to do when patients deteriorate, so with respect or with other interventions. But it's about, again, using those MDTs and all the disciplines within that MDT to the best effect. There is an ask really on local authorities and the CCGs to establish a rolling training program. I mentioned that again at the beginning. Care homes, like many health providers, have a turnover of staff. And so what we need to make sure is that the new staff as they come in are fully, I'm going to say indoctrinated, but you understand what I'm saying, make sure that they're fully immersed in the tools so that when they have a patient who's going off, they actually know what to do. Instead of panicking and ringing an ambulance, or indeed calling a GP practice when actually there's a better offer on that would be available for the patient, is about making sure they understand what those options are. I think the other bit that isn't touched on here, but would probably needs to be thought about more carefully, is about other pathways that we might want to develop and make sure that's so that we can extend the offer of community support. But I'll stop there. I'm grateful that people have taken time to join this. And again, if colleagues could cascade to other colleagues in their practices and spread the word, that would be very helpful. But again, I'm expecting us to have more events like this going forward in the future at various points. And I'll stop there.
Thank you, Steve. So straight over to Leslie, and I think there's been some really pertinent questions in the chat, and I think that Leslie is hopefully going to pick some of those up, and if she doesn't, then we can pick them up in the Q&A session afterwards. So please don't worry if your question hasn't yet been answered, but I can see some of those relate to Chris and the team. So over to you, Leslie, I think.
Great, thanks, Dan. So just a very brief slide. I can talk a little bit more in detail on what you've said, answer any of those questions really that have come in the chat. What we offer is an alternative pathway really to attending ED, which ultimately can often end up in a hospital admission. We provide support, advice and guidance to care homes, as well as all other partners, so West Midlands Ambulance, GPs, community staff. And one of our main aims and one of the positive things that we do is the education and empowerment of the staff within the care homes to look after their residents. I'm really passionate about knowing that the care staff within these care homes look after their residents beautifully, but they need some assistance, education and empowerment, like I've said, to be able to continue doing that. So they can access our rapid clinical input in order to keep the residents in the usual place of residence. And we've broken down our two offers really from our service. The first aspect is the Unscheduled Care Coordination Centre, which operates from 8 till 8, 7 days a week. And that's the triage centre that is staffed by admin and triage nurses. We try and look at this as a single point of entry really for any deteriorating patients, residents who may need clinical input, who would have gone to ED. Ordinarily, you'd have called 111 or 999 for these patients. We've done a huge amount of work with the care homes in particular during the pandemic. And part of that hasn't just been around the deteriorating residents, it's been looking at PPE, infection prevention control, and also cohorting patients correctly. And I think the relationships that we've built up over the last 18 months, we want to continue working on those really, and just share with them what fantastic work they're doing, but we're here to help them as an alternative. Our referrals are allocated to the most appropriate service, so it's not always our CRIS 2-hour rapid response service. We would attend for any acute infection, and certainly around that new scoring that we've all been discussing, we do keep quite poorly patients out in their own homes, and we want that clinical conversation really with anyone that feels that their patient may be falling off that cliff, maybe becoming unwell. We've also got other pathways we can refer into our district nursing community teams. They would visit within 4 to 24 hours, and that's for things like block catheter, wound care, or planned care that is ongoing, but perhaps the patient's been discharged and again is becoming a little bit unwell. We do ask for a set of clinical observations. However, we are flexible around that, and we understand, as someone has put in the chat, we wouldn't expect all residential homes to be able to provide that. A lot of them in our area have got the kit, so a blood pressure machine, a thermometer and a stats probe, but the main reason that we have to obtain these observations are for us to ascertain that the patient's safe to be left for 2 hours really as part of our triage process. As I've put there in quite in bold, we will accept your call, however, if you're unable to provide this, and we want you to call us and have that discussion. We will do a more robust triage just to try and find out what exactly is going on with the patient and see if we've got the capacity to respond. So the second part of our service then is our CRIS, so our Community Rapid Intervention Service. That's made up of clinicians from all walks of professional life. So we've got acute nurses, we've got paramedics, we've got physios, we've got community staff. They have all got an array of skills that they bring to the team. Critical care nurses, as I've said, district nurses, and we want to sort of assess, visit the patient, treat them, implement any medical management plan and prescribe any medication. That team works from 8 in the morning till 10 at night, just because we have to have that 2-hour window after the last triage of being able to respond. As I've said, they are advanced practitioners. Their scope of practice and their prescribing scope has grown immensely over the last 12 months. Because we remained a patient-facing service, we've had to do that. We've had to look after sicker patients that didn't need to go to ED. We've taken on palliative and end-of-life patients and offered a 2-hour response around anticipatory care planning, around implementing the respect and do DNA CPR. We want to continue that, and particularly working with our primary care colleagues of how we can sustain that together and work in partnership. The patients that we see are admitted onto a virtual ward. So how we describe it is we take ED to the patient within their own home. We look after those patients, we review them, we treat them for up to 5 days, and then we discharge back into the care of our primary care colleagues. Any medical management plan that is implemented for either advice, support, for any further deterioration is discussed with our 2 consultants. That medical oversight is provided by the UHNM and works really well. We use their clinical systems, we can access diagnostics, and we can gain really rapid access into some of the SDEC areas, so the same day emergency care. The patients are telephoned or visited by the CRIS team as part of the reviews. We don't have to visit everyone face to face. We can have a discussion with family members, and we can talk to care home staff for that ongoing review. And as I've said, the discharge back to the GPs then is a clear outline of what treatment we've provided, any ongoing further advice we've provided to the care home staff, how to manage that condition, and that does include an escalation process. So if the patient was to become unwell, out of our hours of operation, it would be either 111 or 999. As I've said also, we are engaging hugely with our care home, and we want to continue offering the education and support around particularly this project. We attend the MDTs within the PCNs, and we've got a lead that is looking around increasing education and links, particularly with both nursing, residential and learning disability homes. Any concerns, we've put that in bold, and we always add that around your resident's condition, then call the 0300 number. I always say, and any sort of discussion I'm having, is that there's no silly question. The only silly question is the one that you sit on. You have a patient that's unwell from perhaps Monday and wait until Thursday. Give us a call. We'll talk through that clinical conversation. We can provide advice, we can call back the next day, or we can ask you to call back. But we want to build those links that we can reduce ED attendances. And as I've said, a lot of the residents then would be admitted. They may never go back to their residence within the residential or care homes. And we just want to be able to provide right care, right time, right place, really. A couple of the questions that have been asked are, is it for nursing and residential and learning? Yes. We will come into whether there's qualified nurses or not. We see ourselves as that senior clinical escalation process for anybody, really. Regarding the whole patch, currently we cover, as Steve said earlier, North Staffordshire, so Moorlands, Newcastle and Stoke-on-Trent, but we also have an offer down to Stafford and surrounds. We are just working through a model now, what Cannock and Rugeley will look like. And we've also got support from our RWT colleagues from the Rapid Intervention team who cover the Seasden-Wombourne area. We are hoping to roll out a test of change at the end of August, where we'll be looking at East Staffordshire, so your Lichfield, Tamworth, Burton, Derby areas. The model will be identical. That obviously will just have support from consultants at Derby and Burton Hospital. The Unscheduled Care Coordination Centre will become a pan-Staffordshire access point. We try and advocate that it's on a trusted assessor basis. We don't ask, we don't re-triage. It should be a one-stop shop, and it should be easy to access. So if there's any feedback that is ever that you could provide that's really useful, it's around if you get any delays accessing, if patients you feel have been declined inappropriately, but we would always try and take the patients from you, and as I say, pass them through then to the most appropriate service. I'm just looking if there's any other questions I haven't covered. I think there was one earlier. Somebody had asked around the times of when we're sort of getting calls, particularly from WOMAS conveying to ED. I'm not sure that we can put a time. WOMAS do share with us regularly that when our hours of operation finish at 8, that they feel that there's no alternate pathway to that there's available at the moment. So we are looking at extending our hours of operation. We're just trying to collate the data around that cost effectiveness, really, around how can we support our patients, ensure they don't go to ED, but actually having a cohort of staff on duty for 24 hours. I think that's the ultimate aim for that 2-hour rapid crisis response. It's measuring it up then and getting that model right. Are there any other questions anybody can see that I haven't answered?
Yeah, there's one question from Catherine saying, I'd like to know how to make MDTs work. Our care homes just say that they have no patients to discuss. Next time I will talk about this webinar. How do others make MDTs more effective, please?
Okay, so we've been working on that really, Caroline, and it's around the questioning. Our ACPs, our advanced practitioners, are all aligned to our care homes within North Staffordshire, and we try and encourage them to have a weekly, we call it a weekly ring round. Rather than asking the question, is everyone okay, what we go in with is a more probing question. So particularly around, are there any residents that you're concerned about today? It's putting the onus on them for them to start thinking differently. So it's not about, hi, are your residents all okay? Because they will say, yes, they're all right, thank you. If you do a little bit more probing and delving, use examples of, we came to Mrs. X last week, is she feeling better? They would start thinking of, well, actually, Mrs. Y and Z has got exactly the same. For us, it's accessing us earlier on in that journey, rather than waiting for that time scale when they have deteriorated more and they're not safe to be left at home. I think Sharon, that's leading on our MDT, has found it quite frustrating and slow process. But I think it's that continual engagement, and I've said linking with the right people within the care home. It's no use ringing a care home and talking to the cleaner, as it were, or getting somebody to ring you back. It's about encouraging that clinical conversation and that continual conversation, really.
And yeah, and maybe saying, you know, have you got any residents that have increasing frailty that you're concerned about, or anybody showing soft signs of deterioration, or anybody approaching end of life that you need support with? There was another question around the border of Wolverhampton, and I believe it's the RIT team within Wolverhampton that would cover that. The Rapid Intervention team in Wolverhampton, who provide a similar service to the CRIS team.
They do, yeah, they do, and they've got a very similar model to us. Those referrals currently for that area come again through our Unscheduled Care Coordination Centre, and then we pass them directly through to the RIT team. But we've done a huge amount of work with them to try and out the sort of geographical area coverage, and we'll continue to work with them to get that right.
Brilliant. And would you be able to outline the next slide, Leslie? The one that outlines that.
Yeah, certainly. So we've worked, and again, one of the things that working with care homes is they like something visual. They don't want to be reading reams and reams of documents. So we feel that this is a really easy, quick access document. We've flipped it around, we've changed the colours, we've worked really hard collaboratively really on this document. It's not fully completed. There are people that are still coming forward that would like to be included. There are examples of other services that we've not perhaps thought about or we weren't aware of. So I think this will be a moving feast. We'll continue our doing, but this is version 1 that we would want to share with care homes and ask for comments, really. It's looking at the most on sort of the left hand side, the social care aspect, and I've just actually come off a call with the social care colleagues of how we can support them. They have a great deal of patients that they're going through assessment with, statutory assessments, but actually they feel in their guts that these patients are unwell. So we want to work with them again and look at how we can support them and ensure their patients don't end up in hospital unnecessarily. So I think really with the colour code, it's around the escalating clinical need of severity of how poorly the patients are. These options as we move up to that red section are for you and care home staff to think about their deteriorating care home residents and what is it they need. We know for severe loss of consciousness, chest pain, anybody who thinks choking or having a stroke, it would be 999, and we're never ever taking that away. from care home residents or people that know they need to call that number, there is always a need for some patients to go to ED. I suppose moving backwards for that then is the conversation that I've just had. We can keep really poorly patients within their own homes by utilising our service. So we want you to use that or the 111 who do refer directly into the CRIS service as an escalation. And again, that conversation of discussing how you can keep your patients at home. GPs obviously are within hours, and everybody knows that we greatly need our GPs. They are inundated with work currently, and they have been for a long time now. So it's how we can all support and ensure the right pathways really are adhered to. As I talked about the unscheduled coordination, we can then access all of those other teams, so community nursing, palliative, hospice care. We link in with our mental health colleagues and our social care colleagues to ensure the right outcome and experience for the patients.
Right. And there was just a question in the chat about whether this services would be applicable to residents in their own home. And I don't know who SBART 3 is, but they came back and said it would be available to residents in their own home.
This document won't be at the moment, only because some of these numbers are just professional lines at the moment, Caroline. So yeah, particularly our unscheduled care is just for professionals. We have discussed whether we needed to open that out to patients and relatives. Unfortunately, the 111 option is what we want to guide people down, really, that pathway. But from that 111 option, there are all these pathways that are available then.
Brilliant. That's really helpful. Thank you, Leslie. I think we're nearly there now. We'll just go on to the next slide now, as I think there's just a few closure slides. So what we've done is we've put the links to all those videos that we've been sharing with the care homes that Alison Tavaray mentioned. It has the news too. It's got one about soft signs, LD. So there's some really useful, and they're approximately 2 minutes each. They're really easy to watch and they're available for you. And then I think the last slide is probably a closing slide. Is it? Yeah, yeah. I'm just seeing if there's any last questions. Okay, so Catherine's come back and saying we're not clear what the MDT is actually for. And there's a question about
So the MDT, Caroline, do you want me to just?
Yeah, please, if you would.
Yeah. So the MDT is bringing all practitioners really together. What Sharon again, who's been led with this, has been gathering any information really about patients that need to be discussed. So it's about patients who are approaching palliative or end of life. Have we got everything in place for them? Are we sure that they've got sort of an escalation process? Do they want to be conveyed to hospital for further treatment? Are there, and it's around their wishes and wants really. Other things are patients who again are approaching sort of frailty, who have perhaps had 2 or 3 admissions in the last 6 to 12 months into hospital, and what can we look at differently for those patients? And then some of them are also generally discussing if you've had an outbreak of infection in a care home, if there's concerns around delivery of care, or like I said, cohorting of patients. That MDT is literally an aid memoir for all, for the GPs, for palliative care, for the care home staff, for our CRIS team, to all have an input of improving and getting it right, really. Does that answer your question?
Catherine, does that answer your question? Should we stop the slides now and then we can go on to see people so they can pick up any thanks, Naz. We've had some really great questions in the chat, which shows you're all listening attentively. Catherine, do you want to come back and see if there's anything you want to add to Leslie's response? What? Do you want to unmute yourself and put your camera on?
Caroline, can I just, there's a question from Catherine about, does the MDT replace the walk around by GP? And I think the answer to that is no. I think the MDT is part of the weekly GP round. I think it's sometimes the nomenclature gets in the way of it. There was another question earlier on about if we agree that this is a very useful tool and a sort of validated response, about having that conversation with CQC, and I don't think I'm not sure that we've had that, but actually it's a good point about sharing that with CQC, because I think care homes are always looking to show that they're doing quality improvement and the right thing by patients. So I'm not quite sure how we translate that, but we can have that conversation offline.
Mm-hmm. Thank you, Steve.
I think just to comment there, Steve, from a sort of national perspective, CQC is cited on the Managing Deterioration Commission. So they're very aware that there's a plan to use the peer framework to implement soft science tools and frailty tools across care homes. And where we've seen care homes that have started to use those and talk to CQC about them, it has opened up discussions of quality improvement, improvements in patient and resident management, and actually in some examples led to increased CQC ratings overall. So it's been quite a nice sort of shift actually, and I think Caroline, you've certainly had that example.
Yeah, definitely. I mean, homes that can provide evidence of using these tools and changing their, developing their services to promote improvement in recognition and early escalation of residents. It fits all the domains of safe, well-led, caring, responsive, and effective. So again, this would be very, very great evidence for your CQC, PIR, whatever it is. The South Falls team provide clinical input to deteriorating patients. So I'm just wondering whether the South Falls team were thinking that they should be added to that sort of inventory of, because falls are an indication of that somebody may be deteriorating. So we'll have a chat about that offline as to whether we include those contact numbers onto that, because we want to make it as inclusive as possible. So thanks, Helen, for that comment. Okay, are there any further questions? Anybody want to put their camera on and ask a question or put something else in the chat box? If not, I think we'll thanks, we've got some good nice comments at the end there. So I think we're probably at a point to close, and just thank you all for your time. We really appreciate it, and we hope it hasn't been teaching you stuff that you already know, and we do want to work collaboratively. And I think from the AHSM point of view, we've been really impressed with the Staffordshire Stoke leadership teams about how quickly they've pulled this together, and the collaborative working. That sort of last document was pulled together in a very swift format, and so great. So there's a question now: is there an timeline of implementation for the tools? That's a good question. I sort of refer back to the slides that Dan showed at the beginning. So the plan is for, I'll give the shorter term plan, for by 2022, March 2022, that 60% of care homes in our region, and that includes Staffordshire Stoke, will be using these things like the soft science tools, frailty, the stop and watch tool, and News 2, and end of life or personalised support plans, which I'm sure some of you are already seeing, but we have actually seen in other areas an improved quality of those end of life plans. So it is a big piece of work. It's over the next 3 years, but we have got a target for 2022, and we've made a good start with the care homes to have sort of 70 care homes on the webinar in June, May, was it early June? I can't remember now. And plus 70, 80 more to receive the recording. And we've got a further webinar next week, in fact, on the 30th of June, and then another one in July. So the message will hopefully go far and wide. And as Steve said, this is just the start of a journey that we're going to hope to continue. And Leslie's just kindly put her contact details in the chat box if anybody wants to contact her about the CRIS team. But thank you very much to everybody, and we have a good rest of the day, and we hopefully see you soon.
And thanks to Caroline, Dan and Leslie for all the work you've done.
Thanks, Steve.